We are good to go, sir.
Yeah. So sorry for this technical mistake. And so today we are going to discuss emergencies in palliative care. Yes, we do have emergencies in palliative care. Not all the patients are actually present to you with actively dying phase. So as a physician, we should have all the we should have exposure to all the relative aspects. What are the correctable factors? Because one of the principle of palliative care is correct the correctables, and no patient should die of any correctable causes, or no patient should suffer or having any kind of distress because of any correctable causes. So that is how this topic is very relevant as far as all the palliative care practitioner or any healthcare worker who actually practice or advocate palliative care. So managing emergencies or actually assessing the emergencies is very important as far as the palliative care is concerned. So we can actually classify the palliative care emergencies in different domain. Like we neurological, we have metastatic spinal cord compression, seizure disorders, delirium. In metabolic emergencies, we have so these are common. That might be any metabolic derangement, but most of the our presentation, our group of patients, the high prevalence are for hypercalcemia, hyponatremia, and hyperkalemia. We may get some gastrointestinal emergencies like malignant bowel obstruction, all the solid tumors who have peritoneal involvement, or the primary GI malignancy. Those kind of malignancies can present with malignant bowel obstruction. And some of our emergencies are respiratory. So air obstruction may be intrinsic cause, may be extrinsic cause. We may have vascular emergencies in form of thromboembolism, superior vena cava obstruction, acute DVT, the associated pain with vascular emergencies, the sickle cell pain crisis because of the vascular diathesis, hematological like hemorrhage. So any tumor which is present near to the major vessel, or a highly vascular tumor which can actually present to you in form of a massive hemorrhage. So emergencies can be in form of renal failure due to the obstructive uropathy. You might have seen many causes with C endometrium, especially stage 3 onwards, who can have a picture of hydroureteronephrosis and can present to you with obstructive uropathy. Some of the emergencies are related to bone because of the fracture, because of the underlying pathological fracture, and they can actually present with the frank fracture. And of course, pain is emergency. I'm sure you might have got exposure to the pain management, but this is the most common emergency is pain. So managing pain is very important aspects of palliative care. Second might be the infection, alongside because the most of our patients are immunocompromised. Most of our patients are having neutropenia. So most of the patient having malignant wound which can actually get a secondary infection, and the patient can present to you with sepsis, hypotension, feature of septicemia. So these all are the domains of actually emergencies in palliative care. Okay, just a second. Sorry for the interruption. Uh, so let me go to our next slide, please. So if I tell you what are the most common emergencies, this is not a clear-cut data. What are the most common emergencies I have seen or I have experienced in my practice? First is pain crisis or any other unrelieved symptoms, shortness of breathing, might be. Most of the patient actually do come with, although the constipation is a chronic symptom, but most of the patient present with acute distress contributory because of constipation. Of course, spinal cord compression in our priority and top of the list, because that is actual neurological emergency. As far as any homeostasis is concerned, hemorrhage is also one of the our emergencies, because most of the patient present with massive hemorrhage with hypotension, And there are some remedies in palliative care that we can actually control the hemorrhage in some of the cases. Superior vena cava obstruction is also emergencies. Patient present with hoarseness of voice. Patient may present with dyspnea, puffiness of face, dilated veins, congestion of the chest, and it is an emergency because you have to also identify the underlying disease, because for different disease the treatment might be different in superior vena cava obstruction. So it is also important to know the something about the disease also. Okay, when you are managing cancer, you are not actually managing the cancer actively, but you should know in and out information, general information about that cancer, how that cancer can present with. So palliative care is not something that you will need, you will have to know the only the information or the knowledge about symptom management. You have to actually know the underlying pathophysiology, and you have to have some knowledge about the disease. Okay, so hypocalcemia and hypercalcemia is although hypercalcemia is more common, and hypocalcemia is also one of the emergencies. Airway obstruction, shortness of breathing, irrespective of any cause, might it be the acute obstruction of the large airway, might it be the pleural based nodules, it might be the lung infection, might be the large mass. So any kind of a challenge, any kind of insult to the respiratory tract can present with shortness of breathing. And seizure disorder, of course, it can have a reason like metabolic disorder, like in hypercalcemic picture, especially head neck patients with head neck cancer can present primary brain tumor or the secondary brain metastasis, which can actually present with seizure disorder. Patient with hypoglycemia, because most of the patients intakes are low, so patient in a rare instance, a patient can present to you with hypoglycemic seizure. Okay, so these are the common emergencies. One should have a very a prompt response as far as the palliative care is concerned. So yes, in palliative care, you can most of the time actually decide the trajectory of the illness, because you know the underlying pathophysiology, you know how this disease can behave. So emergency in palliative care are seldom unexpectedly. You can always and always expect some of the emergencies. I'm not saying that you can expect all the emergencies, but most of the emergencies we can actually know. So it is therefore possible you should have a very high index for diagnostic suspicion. Like if I say a patient with head and neck malignancy presented with decreased level of consciousness, have the history of seizure, have decreased urine output, you can actually think of hypercalcemia. So a diagnostic suspicion is very much important as far as the palliative care is concerned. Okay, so second point I like to elaborate is have a plan in place that either prevents them or institute prompt intervention. Like if you suspect this patient can present with hypercalcemia, so you actually ask the patient to decrease the dietary intake which have a high potassium, or you can actually hydrate the patient presumably, so that patient doesn't have a high exposure to hypercalcium. You can actually start zoledronic in a patient who is having bone metastasis, some of the emergencies. And always explain the trajectory of the illness to the patients, and always explain the possible emergencies may happen with the patient to the surrogates, family and caregivers. So whenever the emergency case present to you, in especially in advanced disease, and say it in advanced malignancy or the Parkinson, or the patient is having motor neuron disease, so actually you have to know a little bit about the disease also. So you have to know what is the problem. Most of the other group of patients are having advanced disease, so it is always better to ask yourself whether this condition can be reversed or can't be reversed. So if it is reversed, it may not be appropriate to, like if I say for example what I have mentioned over here, it may not be appropriate to treat this patient with hypercalcemia. hypercalcemia in last of
Avinash,
the
sorry
days.
to interrupt.
It is bound to happen because of the metabolic and underlying pathophysiology derangement. Am I audible?
Sir, we lost you a little bit in between, just for a few seconds, I think. Now it is okay.
It's okay now.
Now fine. Is some participants were also saying that your voice was breaking.
Yeah. Yeah. Okay. So if any interruption, please let me know because the internet connection is very unstable over here in my institute. So, so it may not be appropriate to treat hypercalcemia, especially in a patient who is dying or end of life care. But the distress associated with hypercalcemia should be managed adequately even if the patient's dying. So it is up to you. It is up to your clinical judgment. The patient has presented to emergencies and the patient is having advantages, whether you can reverse it or you are unable to reverse it, but you have to always and always provide a symptomatic care for the patient. Supportive care patient may or may not get for the reversible cause or irreversible cause, but the patient should have a symptomatic relief of any cause. So let me start our discussion with malignant spinal cord compression. Although I have actually named many of the emergencies, but today in our 1 hour session, we are not able to cover all those emergencies. But I would like to you people to actually focus on some of the emergencies which are of utmost important in palliative care settings, because these emergencies are very much related to distress and very much related to quality of life of the patient, and some of the emergencies are very life threatening condition and can be promptly reversed. One of the very important emergency is malignant spinal cord compression. So the picture is showing you a common structure of the spinal cord around the vertebral column. So I assume that you might have a basic anatomical knowledge of the compression. Actually, you can classify the compression in like extradural or intradural. So you can actually know the possible underlying cause. So if the malignancy is compressing the spinal cord, am I audible?
Sir, it's breaking a lot. Sir, we would.
Am I audible, ma'am?
Sir,
Your voice is breaking in between.
Sir, you can just turn off your video and try. Your bandwidth is very low.
So I will try with that. Is it audible now?
Sir,
Am I audible now?
Yes, sir, you are audible.
Thank you so much. Okay. Sorry for interruption. So yes, the compression may be extradural or the intradural depending upon the underlying disease. So the important is how you will identify the metastatic spinal cord compression, or here if some physician or the nurse have ever experienced how this metastatic spinal cord compression present usually. Can anyone elaborate 1 or 2 points just in 1 or 2 seconds, please? Any of the physician, how this metastatic spinal cord compression present to you? Any comments about it? Just 1 or 2 points, then I will go ahead.
we have responses coming in the chat. Fractures,
Okay.
weakness, or even
Chat,
paraplegia,
okay.
paralysis, paraplegia, sudden weakness, paralysis.
Yes, yes,
pain.
yes, yes. So most important point over here is, yeah, yes, all of you are correctly, partially or fully, but yes, most of the patient present with pain. So how you will identify malignant spinal cord compression? Because patient may not present to you with frank paraparesis. Patient can present to you with pain, bit weakness in the bilateral lower limb, but may not a frank weakness that you can establish the diagnosis of paraplegia. Yes, so the most important diagnostic symptom will be low back pain. Especially this pain aggravates with incidents like coughing, sneezing, walking, or sitting from a lying down position. This pain aggravates at nocturnal, means patient is having feeling you more pain at night. And if you examine then in most of the patient you will get local spinal tenderness. It's not in all the patient you will get a localized spinal tenderness. And if you correlate with the imaging, you will find that patient having the bony deformity or bony obstruction or metastatic involvement, like the most of the patient with prostate cancer present with sclerotic lytic lesion in the vertebral column, especially in
I think we lost Dr. Avinash Tiwari for a moment. Kindly stay tuned in.
patient present with back pain. So the characteristic of this pain is night type pain. It aggravates with any incident like coughing, sneezing, sitting out of a lying position. The patient actually have more of pain in night time. Patient may present with local spinal tenderness, but that's not necessary. Burst. In most of the patient, after the pain, the second most common finding is neurological deficit. So, like in 95% of the cases, patient will present to you with back pain, and few of the cases, like in 82% to 85%, that's a quite a common, not few, but will present to you with a neurological deficit along with a component of neuropathic pain. That might be a regular radicular pain or record pain also, or radiating pain also. Ball and bladder involvement is not very common. You can say like 45 to 50% cases will have ball to bladder involvement, and sensory phenomena may or may not be present. But the diagnostic is pain, nocturnal pain, incidental pain, local spinal tenderness, and neurological deficit with a radicular pain. If this picture a patient is having, you have to have a highly suspicious clinical diagnosis of metastatic spinal cord compression. So how we will manage? Most important thing. So most important things we forget when our focus is too much upon the pharmacological management. First and foremost thing, always and always start with spinal stabilization. So this is the part which is very much neglected as far as the, because our whole focus actually be on the pain management. But the most important thing is spinal cord stabilization. Pain relief. So yes, opioid in some circumstances may be very helpful, although the opioids are not very much helpful in bone pain. So you have to take help of other adjuvants. You have to take help of step one analgesics like NSAID or paracetamol, dexamethasone. So dexamethasone invariably you have to use, and the starting dose can be 8 milligram to 20 milligram. And recent evidences say you can also start with per oral dose because the bioavailability of dexamethasone is quite good. Okay, so that is 16 mg per oral, and I usually start with 8 milligram IV stat dose, and that actually decompress the neuroinflammation over there. And actually, dexamethasone response is very much will give you a very much prognostic information how much this patient is going to response to the radiotherapy. So the response from the steroid is very much prognostic information as far as this metastatic spinal cord compression is concerned. So radiotherapy is helpful if you have the acute presentation and the patient has presented to you within 72 hours of this limb weakness or the pain. So any symptoms. So most of the patient we actually get after 72 hours. So for those kind of patient, we do refer to the radiotherapy department but that is actually to manage the pain rather than trying something for to relieve this compression. Okay, so in 60 to 90% patient will achieve the adequate pain relief with dexamethasone followed by radiation therapy. So that's why how it is important to enroll the multidisciplinary facilities in palliative care emergencies. Okay, so, and if the patient is having ball or bladder involvement, especially most of the patient present with bladder involvement, you have to put Foley's catheter. So I assume that you all know how to put Foley's catheter and how to take care of a catheter in situ. So, but the important thing is this patient is going to go to home back after few hours or days of treatment. So whether you empower this caregiver how to take care of this Foley's catheter, that is very important. And this is how we differ from other physicians as a palliative care physician, that you not only just actually manage the emergencies, but you also empower the caregiver to take care of the patients at their local basis. So always and always teach the patient how to take care of the spine, how to provide the spinal support, what are the precautions they have to take, or how to clean the catheter, how to clean this catheter, how to take care of this Foley's catheter. Yes, advise them to drink plenty of fluids, so that because this patient is going to have a urethritis some another day because there is polycatheter in situ. So always encourage plenty of water for this patient to get rid of the infection. And these are the common guidelines. You also know that change the Foley's bag when it is 2/3 full, change the proper latex Foley's every 14 days, and the silicone catheter can be kept for 28 to 30 days. So these are very important aspects as far as the palliative care is concerned. So the catheter may block this part in home care basis, and because of the debris, because of the hemorrhage, because of the displacement, because of the constipation. So you always and always explain this to caregiver that these circumstances, this event may occur. So do not worry, liaison with your local physician and get rid of the complaint. And most importantly, this patient may or may not be able to walk again. Okay, so it's very important that you explain this patient and caregiver about the skin care, especially bed sore care, because this patient is will be on bed because of the advanced disease and because of the this onset of weakness. So it's always important to teach them how to assess the skin, how to assess for the bed sore, how to prevent for the bed sore, and how to take care of such patient, both prophylactically and both prophylactically and how to care for the bed sores. So the I'm sure that you might know in the bus. Just a quick reason: always and always try to reposition such kind of patient on home based care every too early. If available, always try to use air mattress or the water mattress. Explain the caregiver how you actually assess for the onset of a breach in skin or the bed sore. So teaching is very important, and also explain them about some of the dressing material. All the because all the time you won't the patient won't get a doctor. So on the so it's very important to teach them about something that how they can take care of this bad sore or wound at home level. So three dressing material what I used to prescribe them some on anticipated basis or on the day-to-day basis, because this bed sore will be a highly exudative wound, and some of the wounds will be infective. So metrogel gel is a very useful for the infected wound, but some of the patient will have highly exudative wound. So in such kind of patient, hydrocolloid dressing is of very useful set, very useful dressing material. And always demonstrate dressing to the patient and teach them how they should take care of such kind of wound and home level. So, and when the patient is walking and suddenly the patient become wheelchair bound or the stretcher bound, there is a lot of distress associated with patient. and especially with caregiver. So it's always important to provide caregiver support for the patient who have faced the metastatic spinal cord compression. Most of the patient don't retain this power again, and they have the anxiety associated with this prognosis that they won't be able to walk again. So it's very important to counsel them. It's very important to counsel the caregiver, especially because it is the caregiver who is going to reside with the patient all the time. Okay. So the prognosis depends upon the radiosensitivity of tumor. It depends upon the underlying malignancy. Like the patient who's having myeloma, prostate cancer will have excellent response with palliative radiotherapy. But the patient who are having but the patient who are having actually other colorectal cancer, you can say the mixed kind of lesion you get in spinal cord compression. So this patient having a relatively bad prognosis as far as this response to radiotherapy is concerned. Most of the patient with having multiple metastases, or alongside that if they are having visceral metastases or brain metastases, it is already extensive disease. So the disease burden itself gives you the prognostic information. And if, of course, delay in diagnosis and presentation is also very having the bad prognostic association. Involvement of ball and bladder is also bad prognostic, uh, uh, bad prognostic indicator. So these are the delivering this prognostic information to caregivers, and if they allow to the patient is very important, because it will decide whether this patient is going to walk again or not. And most of the time we bluntly say some of the statement to the patient, such kind of patient. So there are some phrases we have to avoid in such kind of patient. Okay, what do you want us to do? You want us to walk, make this patient walk? Please do not use such kind of that. And some of the patient may be on just supportive care. They may not get any cancer directed treatment or disease directed treatment. Do not tell them that we have withdrawal the care. And so do not use that we can't do nothing. In any point of time, even the patient is dying, you can do something. So never that you can't do nothing. So, and at some of the time we take care of such patient, the relatives expectations are too high, and some physician do use that, do you want us to do everything? So some of these phrases should be avoided, especially with a patient present with metastatic spinal cord compression. So this is how we actually have a we should manage, like start from the medical management up to the management of the anticipatory crisis at home level, empowering the caregiver, counseling the caregiver, and the counseling of the patient, and how we should communicate to the patients and their families when we state about this very drastic emergency which is known as metastatic spinal cord compression. Second emergency I would like to take will be raised intracranial pressure. You might know that this patient, most of the malignancies with aggressive behavior, having the brain mets, or the patient will having a neoplastic meningitis or involvement neoplastic involvement of the meninges, can present with raised ICTs. So you know how it presents. It presents with blurring of vision, projectile vomiting, altered sensorium, headache, irretractable, sometimes seizure, or any focal neurological deficit. And it will be always and always acute onset, progressive, and fluctuating course. If you talk about the cancer, the lung cancer having the 50% incidence that it will metastasize to brain, and 20% with breast cancer will have these features. So you start with anti-edema measures. So I'm not going again for the caregiver counseling part and how you should talk to the caregiver. Directly coming to this medical management part, you always start with steroid. In this case, your dose of steroid is quite high with compared to metastatic spinal cord compression, because the need of steroid for penetrating this blood-brain barrier will be quite high. So the 16 to 24 milligram, again, it should be IV and per oral both. But if the patient general condition is poor, you can start directly with IV. And it should be on taper basis, but if there is no response in 3-4 days, it is unlikely that it is going to respond to WRT. So always and always take a radiation oncologist opinion for consideration of the WBRT, because that may actually decompress the edema and the effect of tumor, so that the patient can have a better control of the symptoms, and in some circumstances it may also prolong the life of the patient. So WBRT, taking the reference for WBRT is very much important. For the acute management, for to reduce the intracranial pressure, mannitol is of very much you can start with 20% 100 ml mannitol consecutively for 3 days every 8 hourly. But it's very important because it may actually cause hypotension, so you actually have to have adequate hydrate the patient and monitor the blood pressure. Once the patient's acute decompression therapy has settled, patient is not settled, but there is chances patient may present with recurrent intracranial pressure, raised intracranial pressure features, you can put on maintenance glycerol for this patient. And in some of the cases, although evidence is very much lacking, for the refractory cases you can consider furosemide, that might be a 20 milligram IV 8 hourly in hospital setting. And in home based setting also you can start with very cautiously monitoring of the BP and hydration. In home basis I usually prescribe 20 mg BD, and I actually avoid the night dose of the Lasix at home basis. And the analgesic, of course, it is an inflammatory pain, so paracetamol and NSAIDs are drug of choice. Opioid is not of much useful for the pain related to raised intracranial pressure. Okay, so and more, it might present with like a cranial neuralgias also. So adjuvant are indicated on SOS basis. Status epilepticus, like the patient who have more than 5 minutes of continuous or more than 2 seizures with incomplete recovery of consciousness, you will designate such kind of patient with status epilepticus. The treatment is like any other medical emergencies, in ABC, airflow maintenance, breathing maintenance, and maintenance of the cardiac function, oxygen. To start with, actually you can give injectable dose of midazolam depending upon the body weight. For adult you can directly start with 2 milligram IV dose. Yes, but if the patient goes home after managing these emergencies, there is quite chances patient will have another episode of status, and patient may or may not have access to the physician in nearby places. So always what I do is I prescribe this nasal midazolam spray, which can be put in the each nostril one puff if the patient have any status at home. And rather if they get a physician, they can bring the patient to hospital, or rather local physician can see the patient on home basis. If the patient's seizure is not controlled, you can escalate to the levetiracetam or phenytoin. And actually we should start levetiracetam on a maintenance basis, or because once the patient gets seizure, it is quite chances the patient will have recurrent seizure. And status epilepticus management differs from hospital to hospital. So I recommend you actually follow your hospital protocol. What I start with lorazepam, then I proceed to phenytoin or phenobarbital, and if not controlled, then I go to deep sedation, especially in the patient who are having a terminal stage seizure. Okay. So acute or subacute airway obstruction, that might be intrinsic cause, like the patient who's having the malignancy near neck, which can compress the trachea or the larynx. Secondly, a patient who's having intrinsic tumor or intrinsic laryngeal tumor or the endobronchial tumor. So this and airway obstruction can present in both the cases, intrinsic obstruction and extrinsic obstruction. The features will be acute onset or subacute onset, shortness of breathing, inspiratory stridor, pain, or patient will have a toxic look, or the patient looks like in distress, because he's not going to tell you the symptoms. You have to actually observe by symptoms. Yes, it is an obstruction feature. To start with, maintain secure, if possible, secure the airway. Start with oxygen, start with high dose of steroid, because this decrease the edema and provide some of the relief. Opioid is of much use because it decreases the perception of the breathlessness, and the breathlessness is associated with anxiety because God has made us that we should not perceive our breath. But once the patient having this insult and patient start experiencing his breath and he become breathlessness, his anxiety component also dominates. So some of the time benzodiazepine is also of very much useful. Take a radiation oncologist opinion whether this mask can be radiated so that decompression may occur. In acute setting, always try whether this airway can be secured or not secured. And any point of time, always try to relieve the distress or palliative sedation if the patient is end of life care. And education of the family and support to the family is a very important part, because a caregiver or a surrogate can't see their patient in such kind of event. So explaining them the underlying pathophysiology in the layman term or the term they understand, and always explaining them the prognosis, and always ensure that we are there to take care of for them even if the patient is dying. Hemorrhage, most of the patient in cancer setting having the catastrophic bleeding. This might be the lung mass who had presented with hemoptysis. This might be a primary GI tumor which can present with bleeding per rectum or the hematochezia. This might be a gynecological malignancy. That is because of the direct invasion and resection by the cancer tumor, cancer per se. But most of the patient having the cancer related complication, like the patient is having leukemia or the lymphoma, this patient will having the bone marrow involvement. So there is a per se decreased platelet count. So this patient will present with hemorrhage. So may region be very much different, but the management in palliative care setting is more or less same. Some of the bleeding may be because of the mucositis post radiation, post chemo, they have the bleeding. It may not be massive bleeding, but they present with bleeding. Thrombocytopenia related to chemotherapy use, or use of anticoagulants in patient with pulmonary thromboembolism, or the use of NSAID for the pain, or the patient who is in on pain management, for the pain management on chronic NSAID use. So such kind of patient may present with bleeding or hemorrhage. Some of the patients who have advanced liver disease, so their coagulation profile is most of the time deranged. Most of the patients who are on bed bound having the DIC or DVT may present with bleeding. And some of the are in very rare circumstances patient with a primary coagulant defects. So these are the common causes of hemorrhage. And because knowing the cause is very important, and according to which disease is related to this presentation, you will treat the cause. But the initial principle is like same. Airway, breathing and circulatory maintenance, transfusion as and when required. Always use restrictive transfusion, like a patient who is actively dying and you are expecting few hours or days of life, you're not going to transfuse such kind of patient. But of course we will try to get rid of this active bleeding. Use of tranexamic acid, use of vitamin K, especially when the liver function are deranged. If you are planning any procedure, or you are planning any ascitic tapping, but the platelet count is low, you can take help of the fresh frozen plasma and RDPs. So it depends upon case to case. There is no standard treatment, and it always different from case to case. But these are the medical common medical management of some bleeding diathesis. But that the patient who is dying and present to you with terminal hemorrhage, especially the patient who are having large mass or ulcerative fungating wound near the major vessels, so you always try to consult the family that the prognosis is very poor. We may not get rid of this hemorrhage. Do not transfuse such kind of patient. This will be medical futile treatment. But always try to reduce their distress by giving opioid, giving some suction, using some dark color towels to cover the blood. Because seeing the blood for the caregiver is not easy for the patient who are suffering or facing the terminal event of cancer or any advanced illness. Try to sedate this patient. You can use midazolam. If available, you can use ketamine. And most importantly, be there. Delirium is another emergency most of the time in palliative care setting. Can anyone tell me what type of delirium is most common? Can anyone tell me what type of delirium is more common in palliative care setting? Hyperactive, hypoactive, or mixed? Am I audible?
Yes, sir, you are
Usually
audible.
hyperactive.
So mixed kind of delirium is most common in palliative care setting. Okay, and because and if you ask me per se, which is more prevalent, so hypoactive delirium is more prevalent, but we don't acknowledge hypoactive delirium. That's why it is most of the time missed. So that's why most of the time this hyperactive delirium presentation is common, but the prevalence per se hypoactive delirium is more common. Okay, and our group of patients usually have this mixed kind of delirium. So three different answer for single question. So delirium is actually a fluctuation in the level of consciousness, and it can present with agitation also, and it can present like withdrawn behavior also. So this is a score known as nursing delirium screening scale, NURSAC, and you actually have it in your phone or in your OPD, and always try to assess for this delirium in your setting. Uh, so these have the component of disorientation, inappropriate behavior, inappropriate communication. Patient may present with hallucination. Patient may have psychomotor retardation. So these are the feature. You mark them, and you actually have, if you have the score more than 2, means the patient having the positive screening for the delirium. In palliative care setting, it can delirium have various pictures, because it can be contributed because of the sepsis, it may be contributed because of the hypercalcemia, it might be contributed because of the hyponatremia, it might be because of the excessive opioid, it might be anticholinergic, it might be environmental, it might be brain metastasis, it might be hepatic encephalopathy, it might be acute kidney injury, it might be the any drug related to palliative care. So the underlying cause may be, you can't actually count on fingers. Such kind of etiology may happen in the delirium. So keeping the high suspicion for the occurrence of delirium is very important. So always try to assess a patient who is having. Do not say that the patient is in depression, that's why he is not talking. Patient might be in hyperactive delirium. Always try to differentiate depression and hypoactive delirium. And I'm sure you might have classes earlier for the pain, but acute pain crisis is very much actual crisis in palliative care setting. So any patient who reports, or the family member reports, or you feel the patient pain score is more than 7 on numerical rating scale, this patient is having acute pain crisis and should be attended promptly in any point of time or any place of the hospital, may it be OPD, may it be emergency. So it is very important to attend this pain. So you can start. So basically, because it is a severe pain, you have to secure IV line, and to because, and the drug of choice will be morphine. You have to prime the patient with metoclopramide, because patient the giving morphine injectable is most of the time in 70% chances is it will cause nausea and vomiting. If the patient is already on morphine, try to titrate the breakthrough doses for that patient. If the patient is opioid naive, to start with the low possible dose, and then escalate the dose as per the need of the patient. If the patient is opioid naive, you can start with 1 milligram dose, and you can go up to 10 milligram, but most of the time 10 milligram is not needed. So 1 milligram you give, assess the patient after 5 minutes, and always assess for the nausea and vomiting also, and you can escalate and titrate the dose accordingly. I'm sure you know the T half bioavailability and any pharmacokinetic and pharmacodynamic of the morphine, that I'm not going to explain over here. But the important is identifying the acute pain crisis, have access to morphine, give some anticipatory medication, for the side effect associated with the morphine. So that is how you manage the pain crisis, and not just managing the pain, also managing the side effect associated with morphine is very important. It can present it with you sedation, confusion, delirium, as I already explained, hallucination. Most of the patient will have pinpoint pupil. Most of the patient will have myoclonic jerk. So if you get a decreased respiratory rate with pinpoint pupil and myoclonic jerk, directly start naloxone. Do not wait for anything. So this is the most classical triad for the opioid toxicity. Okay, although it can present in form of sedation, confusion, delirium, hallucination, but if you get pinpoint pupil, decrease respiratory rate and myoclonic jerk, do not wait for anything. Directly start naloxone. That starting dose will be 0.4 milligram in 10 mNLS over 2 minutes, and always try to, because it is very short acting, always try to assess every 5 minutes till the patient gets satisfactory respiratory status. That will be more than 12 to 16 per minute. And I don't think that I have more slide. And any question I would like to happy to take. I know I have covered very few emergencies, but these are the emergency. I want you people to be very promptly, and this management should be at your fingertips. Any question?
Thank you, Dr. Avinash, for that wonderful presentation. Now the forum is open for questions.
All of you can post the questions in the chat, or you can use the raise hand option.
So I one question here I can see is the spinal cord compression due to any secondary radiotherapy in indicates not necessary. Most any tumor which are known to have the radio sensitivity and have presented to you within 72 hours, you can take a radiation oncologist opinion for the radiotherapy. But the response to steroid is a primary thing a physician has to assess. If the patient doesn't respond to steroid, it is very less chances that patient will actually respond to radiotherapy. So yes, in radiosensitive tumor, in any point of time, you have to take the reference of radiation oncologist. Presentation is very important. Patient, suppose the patient has presented after 15 days, there is no point of giving radiotherapy to the lesion. Okay. So the presentation is very important because it is a part of decompression therapy. Yes, you can take radiotherapy reference if the patient is having irretractable pain or bone pain, but it is unlikely that the patient will be given radiotherapy for the gaining of the power again. Okay, so the intent of treatment will be different depending upon the time of presentation. I think you have a case presentation ahead. I have pre-informed you, but I would like to say that I am in the middle of the OPD for this session and my patients are waiting. So I think you continue with the case discussion and I have to discontinue here. Am I allowed to do that, ma'am?
Yeah, sir. Thank you so much for joining. And it was a wonderful presentation from your end.
Thank you, ma'am. And if required, I can share my presentation to you guys. Okay.
Sure, sir.
Thank
you.
you,
Thank you.
Dr. Avinash, for joining us and giving us your time.
Thank you. Thank you
Take
so
care.
much. And see you all again.
Thank
Thank you,
you.
sir. So, with that, we are moving on to the case presentation. Dr. Blossom?
Okay. Am I audible?
Yes, ma'am.
Okay. Good evening, everyone. I'm Dr. Blossom Chako. I am working in Government Medical College, Trivandrum, in the Department of Radiotherapy, assistant professor. I'm presenting a diagnosed case of carcinoma supraglottic larynx, a 70-year-old male who is presented with the complaints of fever and breathing difficulty, pain and ulcerative nodule over the tracheostomy site, and small satellite nodular lesion around the tracheostomy stoma. Coming to the history of the illness, the patient was evaluated for difficulty in swallowing and hoarseness of voice in March 2020. And after ENT evaluation and biopsy, he was diagnosed to have carcinoma supraglottic larynx, modularly differentiated squamous cell carcinoma, stage C4, T4A, in view of extralaryngeal spread, and N2A, stage 4A actually. In view of his age, poor performance status, and extensive disease, was advised palliative radiotherapy, 30 gray in 10 fractions. But unfortunately, the patient and bystanders were not willing for the radiotherapy. Hence, he was started on palliative chemotherapy with injection methotrexate 40 mg flat dose once in every 2 weeks. So even at the time of first TNT evaluation itself, he was advised elective tracheostomy because the glottic space was inadequate, but they were not willing for the same. After 1 month of treatment or 1 month of presentation, he presented with acute stridor to the casualty and underwent emergency tracheostomy. So he was continuing with palliative chemotherapy and palliative care medicines since May 2020. He was but now he had defaulted for 3 months and now reported with pain and ulceration over the tracheostomy site with cutaneous nodules around the stoma. So coming to examination, he had an ECOG performance status of 3. He was reported in wheelchair. His general condition was poor. He had pallor and bilateral pedal edema with a temperature of 100 degree Fahrenheit and regular 100 per minute pulse. BP was 170 and respiratory rate was 20 per minute, and he was using accessory muscles of respiration. On local examination, he had poor oral hygiene. He had mucositis inside the oral cavity. The tracheostomy plastic tube was in situ, but poor air blast was present. Laryngeal crepitus was absent. And there was a 2 centimeter nodular swelling over the lower part of the tracheostomy stoma, which was ulcerated, forming a 1 × 1 centimeter infiltrative ulcer with purulent discharge and maggots in it. So there are multiple total 5 in number satellite nodular lesion, which clearly indicate a cutaneous recurrence, and cervical lymphadenopathy, right level 2 node, 2 × 2 centimeter was there. So the treatment given for that patient was emergency ENT casualty consultation was done. Tracheostomy tube was sectioned and cleaned, and following which his breathing difficulty subsided. And wound care with removal of maggots was done. He had HB 8.4 and total count of 12,000 with platelet 2.1 lakhs. Biochemistry was normal except for a low sodium, and he was diabetic and uncontrolled diabetic. So RBS was 312, which was acetone negative. So he was admitted and he was started on parenteral antibiotics, IV fluids, regular sectioning of tracheostomy tube, and cleaning and dressing of ulcer with saline dressing. And he was started on insulin for diabetic control, and he was taking semi-solids without difficulty, so no feeding procedures were done. And palliative and pain clinic medicines were assumed. He was currently on tab morphine 5 mg Q6H and tab paracetamol 500 mg Q6 hourly. So once the general condition improved, actually he was planned to be started on palliative chemotherapy. Otherwise, if GC deteriorates, he was planned for best supportive care. Coming to the psychosocial aspects, he's staying with his only son's family. He's a widower. His son got a COVID infection from workplace and was admitted in medical college for last 1 month. And the rest of the family was on quarantine, so he had no one else to take care of him. And the tracheostomy stoma left unattended and was infected with maggots. His diabetic control was disrupted because of he was non-compliant and was added to the infection and poor general condition. Due to severe pain, his neighbor actually brought him to our oncology OPD, and examination, he was found to have disease progression, an infected malignant ulcer with maggots, and an intractable pain. His son, who is a manual laborer, now has severe cough and breathing difficulty, which was COVID sequelae, and is unable to resume his work. So this patient is worried about the future of his family. Medication, apart from the palliative chemotherapy with injection methotrexate, he's also on pain and palliative clinic medicines, but he had missed his review. He was on tab morphine and tab paracetamol. So the main concern is first is the infected malignant ulcer with maggots, and disease progression and also pain. So coming to the summary, carcinoma supraglottic larynx with infected malignant ulceration with maggots and intractable pain. So the discussion points, first one is what emergency should be anticipated in this patient and how to prepare the patient and family for that. Second, about the wound care management, then pain management, emotional and financial aspects, and how to deal with the caretakers or educate them. Thank you.
Participants can put in their viewpoints on the discussion points mentioned here.
Thank you, Dr. Blossom, for bringing in a very nice case for discussion.
Okay, thank you.
So the discussion points are like what emergencies should be anticipated in this patient and how to prepare the patient and family for that. So you can put in the comment box what all you think so that it will be easy for us to discuss. As Dr. Blossom had mentioned in the scenario, this patient had come to OP with a history of stridor. So that should be an anticipated emergency for this patient. And in that case, it is very essential that right from the diagnosis, we need to develop a proper communication with the patient as well as the family members regarding what are the things that can be expected in the future. So that has to be done. So communication plays a major part. And the next thing is now the patient had come to the OP with an ulcer. So it is very likely that this ulcer can bleed and there can be some chances of severe hemorrhage. So whenever you see a sentinel bleeding, it's always very important that you communicate with the caregivers that there is a chance for such a severe bleeding and a profuse bleeding which can happen at any time. So these are the very important emergencies that should be anticipated in this case. And participants, you can post your comments in the chat box or you can just raise your hand and communicate with us.
Some comments coming in, like Dr. Vaidyanathan says, upper airway obstruction block, tracheostomy tube.
Okay.
And Dr. Fatima Javi says tracheostomy tube block and breathlessness.
Yes.
Dr. Vaidyanathan continues bleeding from stoma because of recurrence. Dr. Blossom says catastrophic bleeding and the tumor invades blood vessels.
Yeah. So a very nice discussions coming on. So if you have any comments on the same, please feel free to ask us.
Dr. Blossom?
Yes, Dr. Vaidyanathan.
Yes, sir.
Whenever you send back a patient with tracheostomy, what are the things you advise them on tracheostomy care or stoma care rather? Do you ask them to keep a suction apparatus ready at their home or
No.
you want to continue with the humidification the way we do, put a wet
Yes.
gauze or something like that? What are the things you really advise them? We do send a lot of patients with tracheostomy back home. Not very often, but we do get back patient with blocked tubes, clogging of secretions and all sorts of things. So what is your practice has been? What do you advise them?
Yeah, actually, the tracheostomy care and advice is usually given by the ENT department. But what we usually advise them is to keep a stoma protector. It's a type of cloth which they can tie around their neck in front of the tracheostomy stoma, so that no direct infections or no direct lice can be on there or lay eggs, which leads to maggots later. So we usually advise them just to make sure that they can actually feel the air blast by keeping their fingers in front of tracheostomy stoma and breathing in and out. So if they feel some breathing difficulty or something like that, if they feel that, they can keep coming to us or ENT department to get it, the blockage to be removed or suction. Usually I don't know about the humidification at home, how much it can help, but regular humidification can, I think, the secretion won't get blocked inside the tube if they do it regularly. I think what we usually advise is the stoma, keeping the stoma protector, and just in case anything happens, they can either see an ENT nearby or come back to us.
How often you advise or seen your colleagues advising to have a suction apparatus at home, even the handheld suction apparatus?
No, I haven't heard. We never advised to have suction apparatus.
Tracheostomy tube getting blocked is such an emergency. By the time they go and meet up some ENT or land up in some casualty, probably it would have been too late. So they will have severe hypoxic damage. It has happened once or twice to me. One patient turned out to be so bad. By the time they sought medical attention, they came to us. We changed the tube, resuscitated. Already significant amount of hypoxic damage had already set in. So it's challenging actually. I don't know. Probably there is no clear-cut answer for that. Probably.
I don't know whether they are affordable or not. I have no idea.
No, what is the advice you give? That's what I wanted to know. Because we do send a lot of patients.
It's just, normal nebulization they will take at home.
They do take nebulization, is it? You have a nebulizer. Oh, okay.
Yeah.
What one do you suggest? Mucomix.
Muco, something to just to make it the secretions to be liquefy and get, out of, not block the tube at least.
Anyone else from the participants does have any experience with tracheostomy tubes, sending the patients home with tracheostomy? We do send a lot of patients, both head and neck malignancies and say patients with traumatic brain injury or hypoxic vegetative state. We do send a lot of patients back home with tracheostomy. As I said, not very often, but we do get back patient with blocked or partially blocked tubes and all the clogging of secretions. Anybody who have any different comments, sir? You raised.
Actually, in pediatrics, we always use a small suction tube during the cesarean sections. That is very cheap and effective. It is only less than 100 rupees cost. And instead, we can also use a small handheld suction with a collecting number.
Yeah, okay.
In the cesarean rooms, we always use for pediatric neonatal suction.
Do you send it back to the patient? My curiosity was, what advice can we give to the patients, relatives, caregivers? We send them with hospital, it is pretty easy. Everybody is there all.
Yeah, we can ask them to keep it handy when they are having tracheostomy, stoma, and other blocking problems. Then we can train them like that. What we do in our post-operative wards, usually we keep our staff and other caregivers ready with this apparatus.
No, we have tried it initially. The handheld suction apparatus we have tried for a few patients, but they don't seem to be comfortable. As Dr. Blossom was telling, they're comfortable with nebulization quite often.
Yeah, that is true. That is true. Initially, we can even try with adrenal nebulization because some amount of bronchospasm element will also be there. So we try to just enhance the oxygen delivery. The moment the oxygen delivery improves, automatically patient gets some strength to breathe further or cough out the secretions, and we get some more time. So without losing much seconds.
No, sir. My question was entirely different. See, in emergency, it is pretty easy. When they come to EMR anywhere, we just take out the tube and put a new one. It becomes very easy. We do a suctioning. It's very, very easy. My question was, what advice shall we give to the caregivers when they are at home? So at hospital, when they come to hospital, it's all easy, pretty easy. Just take out the tube and put a new one. Things will be taken care of.
Usually settle down. Yeah, yes.
It's very easy. My thing was what to tell them at home, because we do have 2-3 patients like that. I think probably at least in the participants, everybody is facing the same problem like as I think. So we don't have clear.
So actually, we give 8-size pediatric small soft catheter, a small catheter, and we advise the patients to keep it ready. And if there is any chance that they feel there is an obstruction, they can put that catheter inside and use a 20 ml syringe to suck and bring out the catheter also.
In pediatric.
So they can even in adult also. A small 8-size catheter without causing any injury, soft catheter. It will go in the blocked airway and it can create some passage for the air. It is an emergency procedure that we can train the caregivers.
Okay.
That's what we do in our post-operative pediatric cardiac surgery cases also.
Okay. That's one. Okay.
A small catheter will be very easy to pass through the blocked opening.
Thank you, sir, for the comments. So regarding the tracheostomy care, I would like to say what we do at Palliative. We often explain the caregivers regarding how to care for a stoma at home. So in case of tracheostomy, we have an outer tube as well as an inner tube. It is always that the outer tube should always remain inside and the inner tube has to be taken out and it should be put in boiling water for about 20 minutes and then it should be cleaned and reinserted. This is what we advise the caregivers. During our home care service, what we do is we actually teach them how to do that so that once we teach, they get a proper idea on how to do it at home. So this is what we teach them. And also regarding the other opinions and comments which had come previously regarding the humidification, I really agree that in case of tracheostomy, there can be excessive thickened secretions since humidification is lost. In that case, what we do is we go with nebulization, and for home care patients, what we prefer is we prefer steam. It should be the person should be in a position that he shouldn't be going so deep near the steam. He should be somewhat away, and the steam has to be taken on a daily basis so that it improves the humidification. As Dr. Blossom and Dr. Vaidyanathan had mentioned previously, also we suggest them to close the wound always. It's very important because in this case you can see that there had been maggots. So in a case of stoma and whatever wound you see, it's very important that we cover the wound at all times to prevent maggots. So this is what we generally do in Palliative India. Thank you. Moving into the next discussion regarding the wound care management. So you can post your comments and the discussion is open.
Dr. Fatima says turpentine oil for maggots. Okay.
So in this wound, you are able to see that there had been maggots. So it's very important that we know how to remove maggots from a wound. So maggots, what we actually use here is the turpentine oil, as Dr. Fatima had already mentioned. But it's very important that how we use turpentine. Turpentine has to be used very cautiously because it can cause skin burns. So it's very important that we take only 2 ml, soak it in a gauze and keep it over the wound and wait for some time for the maggots to come up. It's because the maggots have a tendency that they go and hide deep into the crevices of the wound because the maggots are photophilic. So when you close it and remove after some time, you open it after some time, maybe after 10 minutes, you can see the maggots coming up. In that case, just take a kidney tray with boiling water, pick out the maggots and drop it in the kidney tray so that they die. So this is the technique that we use. And in patients with maggots, it's very essential that we provide a proper wound care, which has to be provided on a BD basis, maybe in the morning as well as in the evening, depending on the number of maggots which we are getting. And also you can apply a topical metronidazole powder. What we actually use here is the metronidazole tablet. We crush it and we make it into a powder and we apply it over the wound, which helps with anaerobic organisms. And this is what is all about maggots.
Any other inputs from your experiences, like from the patients or cases which you had gone through? Any suggestions? I think we can move on to the next point.
Okay.
Yes, Dr. White. Dr. Mithun had said that always is a tracheostomy tube with inner and outer tube, so that cleaning of the inner tube alone is sufficient, and home-based suction can cause bleeding if not done properly and if done lesions are present. Dr. Vaidyanathan had responded saying that probably for a long-term perspective, default use of tubes with inner and outer tube may be better.
Thank you all for the comments. So regarding the hemorrhage which had come in the chat, so it's always very essential that we prepare the caregivers and explain them that there can be bleeding. In that case, it's very essential that we keep dark towels. When a patient is in an IP unit, we should always keep dark towels beneath their bed so that whenever there is an active bleed, we can just roll it around and we can like help them. So this is the first thing. And also the second thing is we keep anxiolytics ready. Like for example, keep injection midazolam ready. And whenever there is a profuse bleeding, you can give injection midazolam at the rate of 1 milligram as a subcutaneous dose. So this will reduce the panic, because when there is a bleeding, there is associated anxiety and panic among the family members as well as the patient. So it is very important that we deal with that. And moving into the third discussion point, it is about the pain management. So you people tell me, put in your comments on how you will manage this pain. Because the patient was on tab morphine 5 milligram every 6th hourly. And along with that, he was also on tablet paracetamol 500 mg Q6H. So how will you titrate the dose? And what are the things that can be added? Give your opinions on the same.
Yes, yes. Wait and wait. Dr. Vaidyanathan had asked why not time-honored compression oversight to stop bleeding? Simple and effective.
Yeah, sure.
Coming to the pain management, Dr. Premlata has suggested fentanyl patch.
Okay. So now the patient is on tab morphine 5 milligram Q6H. So it's very important that whenever we decide pain management, we should go for a proper assessment of pain. You would have all learned about it in the previous sessions. We always go with the OPQRST. So O is the onset of pain, S the site, then P for the pain, palliative factor as well as a provocating factor, Q for the quality of pain, R for the radiation, S for the severity, whether it is mild, moderate or severe, and for the T is the temporal factor, whether it has got any diurnal or nocturnal variation. So this is how we assess physical pain. But remember, never forget to rule out other concepts of total pain, like the emotional pain. As in this case, we can see there are many psychosocial aspects. So emotional pain has to be addressed, as well as we need to address the social as well as the spiritual pain. So always in palliative care, we go with the total pain concept, which was given by Dame Cicely. So that is how you do a pain management. So in this patient, what you can do is for paracetamol, the patient is on 500 milligram Q6H. So what we can do is calculate the exact dose of paracetamol that the patient needs. Know the weight of the patient. It is always important that we take 12 milligram per kg per dose as the mean value for calculating paracetamol. Then you can make it 750 milligram Q6H, or likewise, based on the weight of the patient, you can titrate the dose. Also, coming to morphine, 5 milligram Q6H, which accounts to 20 milligram, you can increase it to 30% or 50%. That is how we do, depending on the pain assessment. After you do the pain assessment, try to find out the different types of pain. The patient may have not only a nociceptive component, he may also have a neuropathic mixed component. So it's very essential that we titrate the dosage according to that. Maybe this patient, we can increase the dose to 5 milligram Q4H every 4th hourly, and we can give 5 milligram as SOS and 10 milligram double dose in the night at 10 p.m. That is how we titrate. And then further on, at this pain assessment, very important thing is it is to be done on a daily basis. When a patient is an IP unit, you do it on a daily basis, at least 24 hours once, and titrate the dose accordingly. And also never forget to check out for the opioid toxic signs like myoclonus whenever you titrate the dose.
Dr. Vaidyanathan also says that in acute pain scenario, we can switch over to IV morphine titrated if severity is more than 700.
Yes, what we do is when there is a pain crisis, like when the patient comes with severe pain, we start with the morphine trial. As Dr. Avinash had mentioned in the slides regarding morphine trial, that is how we do. We do a trial, we find out the accurate dose, and then make it peroral or subcutaneous, whichever is needed. So yes, Dr. Vaidyanathan, thank you for bringing in that. Any other inputs? Dr. Blossom, you want to add something?
Not actually.
Thank you.
I think we can move on to the next.
So the next thing is all about the emotional and financial aspects. As you can see in the psychosocial aspects of this case, the person seems to be very much affected and depressed because he is thinking about his son. His son is also COVID positive, and there is no one to take care of him. And that is why he landed with maggots. And there had been poor hygiene regarding wound care. So emotional and financial aspects. Coming to palliative care, it's very essential that we involve a multidisciplinary team which assess this on a proper and daily basis. It's like not only the doctor or the nurse who is involved with the patient, it's always the whole team which has to get involved with the patient, which has to look into each and every aspect. When it comes to emotional and financial aspects, it can affect the patient's pain a lot. And when a person, for example, a person physical pain may be very low, but the emotional component will increase the pain, as we had learned earlier. So it's very essential that we involve a multidisciplinary team, arrange a communication, set up an interview with the family members. You would have already learned about the communication protocol that we use. That's the SPIKES protocol that we use for breaking bad news and all. And always it's very essential that we communicate with the caregivers and let them know what is the current prognosis of the patient, how we can help them, and things like that. Any other comments on the same, like how you people, manage a person with emotional and financial aspects? On this case, how would you have dealt with it? Dr. Blossom, you want to say something?
No, ma'am.
Okay. So moving into the next aspect, that is dealing with caretakers. So as I had mentioned previously, it's very important that we teach them how to deal with a patient who has a kind of tracheostomy, who has got some wound, a pressure sore or something. As Dr. Avinash had mentioned, for example, if a person has got a pressure sore, it's very important that we let the family know on how to carry out on a daily basis with that patient. For example, if the person is fully bedridden, we can go for an airbed. And then position change is very much needed, means like every second hourly. When the person is lying, every second hourly, or if the person is bound to a wheelchair, every 20 minutes, 15 to 20 minutes, we need to do the position change to prevent a pressure sore. So in this case, dealing with caretakers, when it comes to tracheostomy care, as I had mentioned before, the proper care on how to deal with the tracheostomy patient has to be explained clearly, on how to boil the inner tube, how to clean it, how to reapply it, and all this has to be demonstrated to the patient's caregivers, and we have to explain them. Also, on a periodic basis, it's very essential that we tell them that this is the prognosis of the patient. Each and every time, we may think that, no, we said only 1 month back, why to repeat it again? No, that's not the case. Every time when you communicate with the patient and a caregiver, find time and explain the current prognosis of the patient and what are the things that can be anticipated in near future so that they get prepared. So that is how we deal with caretakers in palliative care. As I mentioned previously, it is always a multidisciplinary team which gets involved with all of this.
Any other inputs or suggestions? Was in India, do you always use the fuller metallic tracheostomy tube for all patients?
I don't have a proper idea on this. I can collect information and let you know.
This query will
Can I say
be
something? Yeah, can I say something? Most of the
yes,
time,
sir.
whatever we have been discussing, that inner tube, outer tube, and all, that used to be available only with a fullest tracheostomy tube. As you could see in the presentation by Dr. Blossom, most of the time nowadays, what we do send the patients with is a plastic tube. Plastic or the Portex brand, usually the common one, PVC tracheostomy tubes. The PVC tracheostomy tubes doesn't have inner and outer tube, but it is very convenient and very easy to handle. You just take it out and just pull it in. In fact, what we have seen in our earlier days, probably when I was using the metallic tracheostomy tube with the inner and the outer tube, what we call it as a fullest tube, the inner tube, it has got a flange. That flange itself used to irritate the stoma a lot, and it used to cause a lot of irritation, bleeding, and that itself used to create granulations. In that way, the plastic tube was a much better and safer bet. Most of us, we use only the plastic tube nowadays. So with your repeated comments that inner tube has to be boiled, inner tube, most of us, we do send the patients with only the plastic tube, which doesn't have inner or outer tube. Of course, there are multiple variations. So for example, a patient with a laryngectomy, we have a laryngectomy tube. A patient can have a tracheostomy with a speaking valve. Sometimes you get dual walled tubes also in plastic also, but it's not routine. Routinely, we use only the plastic tubes. So it will be better if I get some clarification on that. What is the current practice, actual practice? Because we use only the plastic tubes, which doesn't have inner and outer tube. Most of us, in fact. Dr. Blossom, what is it in your center? Your center?
Yeah, according to, what I conceived is that at first the patients are given this plastic tube, and once they get adjusted or adapted, they will be changed into a metallic tube. That's what I thought. I'm not sure, but I've seen both.
Okay. Maybe in government centers, still maybe they may be using some to an extent, because most of the ENT surgeons, most of the onco people, our own onco team, all of us, we use only the plastic tubes. We do send it to the patient. We use a 8 or 8.5 tube, which is slightly bigger, and we do send it back. Of course, laryngectomy tubes we use when we need to have it in a permanent basis. When the larynx has been removed, we send the patients with laryngectomy tube. Gradually, when they get used to it, we switch out to tubes with speaking valves so that they can close the valves and they can start speaking also. We do have multiple level caregivers, so they train them in speaking, how to take care of the tube with speaking valve and so that they can communicate also, verbal communication. So these are some of the things what we use. Maybe let me find out from other centers what they are using.
What we had actually seen is more of metallic tubes with the inner and outer tube. But anyway, I'll get information regarding the plastic tubes which you people were talking, and we'll share it with you.
Yes, Dr. Vainidhan, your query has been noted and will be forwarded to Dr. Sridevi Warrior as well. And we do hope to get back to you over message or mail as soon as possible. Yes, Dr. Fatima Jabin, you had raised your hand.
I'm myself ENT PG working in Alapura Medical College. So I would like to put some notes on this. Like we usually put plastic tube because it is better in every way. The only demerit is that it is more costlier. It comes around 3,000 and 4,000 rupees for the plastic tube. Whereas we can buy the metal tube within 100 to 100 rupees. That's the only demerit, the cost. Otherwise, plastic tube is better. There are different types of plastic tubes without inner tube and with inner tube, and it is cuffed also, and non-cuffed is also available. So there are different types of plastic tubes. In our hospital, after tracheostomy, we usually put tracheostomy tube with inner tube. So it is for we can send the patient at home and advise them to clean the inner tube regularly. Thank you.
Thank you, Dr. Fatima.
Thank you so much, Dr. Fatima, for that valuable information. Dr. Vaidyanathan, we believe that your query has been answered somewhat. Is there anything else, or shall we wind up for the day, Dr.
If there is nothing else, we can wind up for the day. Thank you all for your participation.
So that has brought us to the end of this wonderful session, I believe. Thank you for joining in, and please don't forget to give your feedbacks because it is very valuable for us. See you in the next session.